WSES Jerusalem Guidelines for Diagnosis and Treatment of Acute Appendicitis Guidelines Statements. Welcome to the Everything Surgery Podcast. Today we look at the WSES Jerusalem Guidelines for Diagnosis and Treatment of Acute Appendicitis Guidelines Statements and the accompanying level of evidence. 1. Diagnostic efficiency of clinical scoring systems. 1.1. The Alvarado score, with cutoff score 5, is sufficiently sensitive to exclude acute appendicitis. Level 1A. 1.2. The Alvarado score is not sufficiently specific in diagnosing acute appendicitis. Level 1A. 1.3. An ideal, high sensitivity and specificity, clinically applicable, diagnostic scoring system clinical rule remains outstanding. This remains an area for future research. Level 1B. 2. Role of imaging. 2.1. In patients with suspected appendicitis, a tailored individualized approach is recommended, depending on disease probability, sex and age of the patient. Level 2B. 2.2. Imaging should be linked to risk stratification such as AIR or Alvarado score. Level 1A. 2.3. Low-risk patients being admitted to hospital and not clinically improving or reassessed score could have appendicitis ruled in or out by abdominal CT. Level 2B. 2.4. Intermediate risk classification identifies patients likely to benefit from observation and systematic diagnostic imaging. Level 2B. 2.5. High-risk patients, younger than 60 years old, may not require preoperative imaging. Level 2B. 2.6. U.S. standard reporting templates for ultrasound and U.S. 3-step sequential positioning may enhance over accuracy. Level 3B. 2.7. MRI is recommended in pregnant patients with suspected appendicitis, if this resource is available. Level 2B. 3. Non-operative treatment for uncomplicated appendicitis. 3.1. Antibiotic therapy can be successful in selected patients with uncomplicated appendicitis who wish to avoid surgery and accept the risk up to 38% recurrence. Level 1A. 3.2. Current evidence supports initial intravenous antibiotics with subsequent conversion to oral antibiotics. Level 2B. 3.3. In patients with normal investigations and symptoms unlikely to be appendicitis but which do not settle. 3.3.1. Cross-sectional imaging is recommended before surgery. 3.3.2. Laparoscopy is the surgical approach of choice. 3.3.3. There is inadequate evidence to recommend a routine approach at present. Level 2B. 4. Timing of appendectomy and in-hospital delay. 4.1. Short, in-hospital surgical delay up to 12/24H is safe in uncomplicated acute appendicitis and does not increase complications and/or perforation rate. Level 2B. 4.2. Surgery for uncomplicated appendicitis can be planned for next available list, minimizing delay wherever possible. Patient comfort, etc. Level 2B. 5. Surgical treatment. 5.1.1. Laparoscopic appendectomy should represent the first choice where laparoscopic equipment and skills are available, since it offers clear advantages in terms of less pain, lower incidence of SSI, decreased loss, earlier return to work and overall costs. Level 1A. 5.1.2. Laparoscopy offers clear advantages and should be preferred in obese patients, older patients and patients with comorbidities. Level 2B. 5.1.3. Laparoscopy is feasible and safe in young male patients, although no clear advantages can be demonstrated in such patients. Level 2B. 5.1.4. Laparoscopy should not be considered as a first choice over open appendectomy in pregnant patients. Level 1B. 5.1.5. No major benefits have also been observed in laparoscopic appendectomy in children, but it reduces hospital stay and overall morbidity. Level 1A. 5.1.6. In experienced hands, laparoscopy is more beneficial and cost-effective than open surgery for complicated appendicitis. Level 3B. 5.2. Peritoneal irrigation does not have any advantages over suction alone in complicated appendicitis. Level 2B. 5.3. Mesentery dissection. 5.3.1. There are no clinical differences in outcomes, loss and complications rates between the different techniques described for mesentery dissection: monopolar electrocoagulation, bipolar energy, metal clips, endoloops, ligature, harmonic scalpel, etc. Level 3B. 5.3.2. Monopolar electrocoagulation and bipolar energy are the most cost-effective techniques, even if more experience and technical skills is required to avoid potential complications, e.g. bleeding and thermal injuries. Level 3B, 5.4, stump ligation, 5.4.1. There are no clinical advantages in the use of endostapler over endoloops for stump closure for both adults and children. Level 1A, 5.4.2. Endoloops might be preferred for lowering the costs when appropriate skills learning curve are available. Level 3B, 5.4.3. There are no advantages of stump inversion over simple ligation, either in open or laparoscopic surgery. Level 2B, 5.5. Drains, 5.5.1. There are no advantages of stump inversion over simple ligation, either in open or laparoscopic surgery. Level 3B, 5.5.2. In adult patients, drain after appendectomy for perforated appendicitis and abscess peritonitis should be used with judicious caution. Given the absence of good evidence from the literature, drains did not prove any efficacy in preventing intra-abdominal abscess and seem to be associated with delayed hospital discharge. Level 1A, 5.6. Delayed primary skin closure does not seem beneficial for reducing the risk of SSI and increase loss in open appendectomies with contaminated dirty wounds. Level 1A, 6. Scoring systems for intraoperative grading of appendicitis and their clinical usefulness. 6.1. The incidence of unexpected findings in appendectomy specimens is low, but the intraoperative diagnosis alone is insufficient for identifying unexpected disease. From the current available evidence, routine histopathology is necessary. Level 2B, 6.2. There is a lack of validated system for histological classification of acute appendicitis and controversies exist on this topic. Level 4C, 6.3. Surgeon's macroscopic judgment of early grades of acute appendicitis is inaccurate. Level 2B, 6.4. If the appendix looks normal during surgery and no other disease is found in symptomatic patient, we recommend removal in any case. Level 4C, 6.5. We recommend adoption of a grading system for acute appendicitis based on clinical, imaging and operative findings, which can allow identification of homogeneous groups of patients, determining optimal grade disease management and comparing therapeutic modalities. Level 2B, 7. Non-surgical treatment for complicated appendicitis, abscess or phlegmone. 7.1. Percutaneous drainage of a periappendiceal abscess, if accessible, is an appropriate treatment in addition to antibiotics for complicated appendicitis. Level 2B, 7.2. Non-operative management is a reasonable first-line treatment for appendicitis with phlegmone or abscess. Level 1A, 7.3. Operative management of acute appendicitis with phlegmone or abscess is a safe alternative to non-operative management in experienced hands. Level 2B, 7.4. Interval appendectomy is not routinely recommended both in adults and children. Level 1A, 7.5. Interval appendectomy is recommended for those patients with recurrent symptoms. Level 2B, 7.6. Colonic screening should be performed in those patients with appendicitis treated non-operatively if greater than 40 years old. Level 3C, 8. Preoperative and postoperative antibiotics. 8.1. In patients with acute appendicitis, preoperative broad-spectrum antibiotics are always recommended. Level 1A, 8.2. For patients with uncomplicated appendicitis, postoperative antibiotics are not recommended. Level 2B, 8.3. In patients with complicated acute appendicitis, postoperative, broad-spectrum antibiotics are always recommended. Level 2B, 8.4. Although discontinuation of antimicrobial treatment should be based on clinical and laboratory criteria such as fever and leukocytosis, a period of 3 to 5 days for adult patients is generally recommended. Level 2B. Thanks for tuning in. If you enjoy our content, please like, share and hit the subscribe button. It's the Everything Surgery Podcast. Dissect the extraordinary.